Welcome back, Care Partners. Teresa Youngstrom here. You know, I'm a seasoned registered nurse or older and realized that I didn't know enough about dementia and had to start doing a lot of research in order to help take care of my own mother. So I've lived this. It was a decade of decline, and I'd been a nurse for 30 years when that happened and realized I didn't know enough about dementia. So we keep searching and looking and combing this world for great speakers who can bring information and shed light that might help you in your situation. And a good friend of mine, Marion Kiner, suggested that I reach out to Lynn Mathre, and wait till you hear about what this woman has done. And I think you're going to be well educated on all of her work in the area of cannabis. So listen up, let me tell you. So Lynn Mathre, she's a nurse, she's a master's prepared registered nurse, has close to 50 years of experience as a nurse and has specialized in addictions nursing since 1987 and cannabis education since 1990. Miss Mathre is a co-founder and president of Patients Out of Time, which was incorporated in 1995 as a nonprofit organization devoted to educating healthcare professionals and the public about the therapeutic uses of cannabis. You can check out their website, medicalcannabis.com. Lynn is the editor of Cannabis and Medical Practice, a legal, historical, and pharmacological overview of the therapeutic use of medicine, science, and sociology. She has served on the planning committee for Patients Out of Time, accredited national clinical conference on cannabis therapeutics. This series began in 2000 and now is an annual event since 2015. Ms. Mathre is also a founding member of past president of the American Cannabis Nurses Association, which started in 2010. She served as charge nurse on the Addictions Treatment Unit at the University of Virginia Health Center and later as addictions consult nurse for UVA Health System until 2002. I mean, this is a long list of accreditations, guys. It's incredible. In addition, she later worked as the executive director at a methadone treatment center. She's been the past board member of the International Nurses Society on Addictions and serves on the editorial board for the Journal of Addictions in Nursing. Please help me welcome Lynn Mathre. Hey, how are you?
I'm doing good. Glad to be with you today, Teresa.
Good. We're so excited you're here. And there's just, so many questions I have. I'm very green and naive in this area. And so I just can't wait to get started because I feel like you're a wealth of information on this topic that so many people either don't know about or either they don't know about or they're just afraid to check and ask. So let's get started. Why is cannabis prohibited by the federal government? Start there.
Lies, lies, lies.
Yes.
What can we say? And racism. Back in well, let's put it this way: the alcohol prohibition ended, and what are we going to do? We got all these cops ready to fight things. So Harry Anslinger comes along and says, there's this dangerous drug called marijuana. Mexicans are using it. Black jazz musicians down in New Orleans and areas like that were using it. And, it leads to murder, rape, insanity. So they passed the Marijuana Tax Act in 1937 to tax it so high. And funny thing, back then, the American Medical Association fought it. They had to testify and basically saying, don't do this. This is a medicine, because cannabis as a medicine was very popular. We knew the docs knew it as cannabis, but marijuana was this new drug that came along that people were smoking. So they did the reefer madness, as we called it back then. And there was a movie, Reefer Madness, which was very popular. And in it, somebody goes crazy and a girl gets raped and somebody gets killed. And that's what happens when you've got marijuana coming around. And it was because it was starting to affect young white kids. So they passed that resolution. And then by 1970, we passed the Controlled Substances Act of 1970. And marijuana was put in Schedule 1. And as we know, the 5 schedules we have in the United States, 5 being the least addictive, 1 being forbidden, dangerous, are opiates being in Schedule 2, cocaine's in Schedule 2, methamphetamine's in Schedule 2, but
Wow.
marijuana and heroin, are Schedule 1, forbidden. You can't use it. No safety to use it, not approved by healthcare professionals, not approved for medical use in the United States, and highly addictive. Those 3 categories to fit in Schedule 1. So it's been there and it's been languishing there, despite there have been cases, lawsuits against the DEA to say reschedule it back in 1988. And that was I think the lawsuit started like in 1971 or something. But finally, Judge Young ruled that it doesn't belong in Schedule 1. And at that point, they were just saying, just move it to Schedule 2. But the DEA, that was the DEA's judge. The head of the DEA said, we don't care. We're going to keep it here. And then there were subsequent challenges. So today, where we sit now, actually, the DEA is looking to put it in Schedule 3, which will be confusing because it's not approved by the FDA as a medicine yet. It's Schedule 3 are, Tylenol with codeine, less addictive than the Schedule 2 meds. And I think that whole scheduling system is funny because, as you said, I've served as an addictions nurse for a number of years. And one of the hardest things I always thought to get people off of were benzodiazepines.
Right.
Benzodiazepines are in Schedule 4. I mean, they think it's safe, but they're highly addictive. Getting someone off Xanax, if they've been on that regularly, is really, really difficult.
Right.
Scheduling itself is kind of confusing. So right now we're in a limbo in terms of the federal government. They're looking to move it to Schedule 3. There's going to be public's, response to all that. There has been, and we'll see what happens. I think it should be descheduled as a plant.
Yeah, the fear mongering has worked, though. They've got people afraid of it, and that's the scary part. What got you as a young nurse? What got you interested in cannabis and marijuana?
Well, I started my nursing career in the Navy. I was a Navy Nurse Corps as a nurse in Portsmouth, Virginia, and down in Puerto Rico. And yeah, I used cannabis throughout my life. I was a late bloomer in that, and used it occasionally. But and then in the early 80s, the military started the drug testing. Let's start it on the military first, and then we'll see about bringing it to the public.
Right.
And of course, that was a big surge, and a lot of people were kicked out of the military who shouldn't have been, different false positives or something like this. A lot of that was opiates. If they had poppy seeds or something like that, they'd get kicked out. But many for marijuana, because it's in your system so long, it's harder for people to fight that. So I was in Washington State at the time, and that got me just thinking about it. So from there, I went to Case Western. We moved to Ohio, and went to Case Western to get my master's degree in 84 to 85. And I did my thesis on marijuana disclosure to healthcare professionals. I thought, well, it's the most used illicit drug. Do we even ask about it? Because I knew in my nursing practice, I wasn't routinely asking about it, in the, hey, do you have any substance abuse problems, alcohol, tobacco? And we might ask that. And we ask about medications, but we never asked. So at the time, I knew there was the National Organization for the Reform of Marijuana Laws, NORML. And they had a leaflet they put out every 2 months, a newsletter. So we're going back in the 80s. It was before the internet.
Sure.
Snail mail, alive and well. And so I asked them if I could do a survey, if I could post it in their leaflet. I thought Nancy Reagan, it was going on that just say no. So if I'm sitting in Cleveland, it's like, well, if I go up to people, they're not going to tell me if they use cannabis or not. It's like, just say no.
Right. Just say no. Everybody should say no.
So anyway, I got a 1-page questionnaire. They put it on the back of their leaflet. People could tear it off, send it in. They sent it to NORML. NORML sends me all of these anonymous surveys. I got, in time to finish my thesis, I got 800 and some. All in all, I ended up with about 900. And at the time, I think they had a mailing list of about 5,000. So the return was great.
Yeah.
Age range, from 18 to 70s. Any kind of job you can think of. We had housewives, students. I had a priest, but truck drivers, teachers, you name it, anybody. Asked about their use, asked about, in terms of asking about, I asked about their if they were ever asked, that was main purpose, were you asked by a physician or nurse? And it was limited at your last visit about your marijuana use.
Yeah.
Most were never asked. Would you admit to use if you asked? And over half, just a little bit over half, said yes, because they probably should know.
Mm-hmm.
For those of you who wouldn't, why wouldn't you? I might get arrested. Their
Right.
attitude,
They're afraid. Mm-hmm.
you know, just all of those negative connotations, scared, I'll lose my job, all this kind of stuff. So, okay. The last question I asked was, what are your health concerns about your use of marijuana? And they could check as many boxes as they wanted to. And I had none, even though I'm a moderate user, or none, even though I'm a heavy user, worried about its effects on my brain, on my heart, on my kidneys, on my liver, on my fetus for any pregnant women, and other.
Mm-hmm.
I got all these write-ins. I'm a spinal cord injury patient. This helps me. I used it during pregnancy for morning sickness. Certainly there were some cancer patients who used it for their chemotherapy, which I'd already heard about. But the other ones were multiple sclerosis. So I'm looking at this and I'm going, wow, well, that's interesting. I knew about cancer chemotherapy and I knew people used it for glaucoma. A few people used it for glaucoma, but what's this other stuff? So then I did my research and all of a sudden I find out the whole history of marijuana, but the longer history of cannabis that's been used throughout the world, throughout different cultures for centuries. This is a plant that has healing products. I have an old, I should grab it. I've got a book, Bloomgarden's Pharmacology book back from 1915 for nurses. And so I looked it up and there's cannabis in there.
Wow.
And it's in bold. They've got it relieves pain and induces sleep. And to an extent, to this day, those are very popular reasons to use it. Chronic pain is probably the biggest reason. And a lot of people find it really helpful for sleep. But it's like that all got washed away, and now all we know is marijuana. We didn't know cannabis. So, that was like, oh my goodness. And then Normal just after that, and part of the agreement was I will share my results with them, so that was interesting for them. Then they asked if I would head the Council on Marijuana and Health, all volunteer positions. But that was great because it introduced me to a lot of people. Lester Grinspoon, who had written Marijuana, the Forbidden Medicine, a Harvard professor, psychiatric professor, which unfortunately through his whole career, that kind of ruined him. He never did get full tenure, which all admit he should have. He was a brilliant psychiatrist, but he was, for cannabis, he was finding that was a good drug and that they couldn't have that. But Andrew Weil, Melanie Dreyer, my mentor, my hero, Melanie Dreyer's a RN PhD, and she did early research of pregnant women smoking ganja, marijuana in Jamaica, and was one of the first studies to really show that cannabis and the birth problems, they try to say there's not a correlation. But in the United States, all our surveys were, more or less of women in poor socioeconomic status. They might not have gotten good prenatal care. Maybe they smoked, maybe they drank, maybe they took whatever. But if they used cannabis anywhere, well, and if there's any problem with the baby, well, it was the marijuana's fault.
Oh, yeah.
So she did that. But anyway, so I did that. And then finally, my husband and I looked at each other and said, this is medicine, but healthcare professionals are too intimidated by the federal law to ever come to a Normal conference and learn about it.
Right. Absolutely right.
We've got to do accredited. But actually, we did, sometimes I forget about this, but we actually had an accredited conference in 1990 in Florida. Melanie Dreyer helped get the accreditation for it. That was a big leap, trying to get someone to accredit the fact that we're just going to give science. It was not well attended.
Mm-hmm.
Again, people too afraid to come to something about cannabis.
Right.
But anyway, we kept thinking this was important. So, and I'd been on the board of Normal at the time. We left that, and in 1995 started Patients Out of Time. And for those listening, we always kept the name for Patients Out of Time, but the acronym is POT. Kind of was easy. But the whole purpose there was to say that patients can benefit from cannabis. And for some of them, it's life-saving. It's certainly improving the quality of their life. They don't have time for all of these research studies. They want it. Every patient I know of wants research on cannabis, but you can't say they can't have it. And as we all know, the primary purpose of research on any new drug is making sure it's safe before you give it to someone. This is thousands of years of safety. I mean, and to this day, it doesn't kill people. Right. Yes, it's getting stronger today. And yes, some people are using the experimental cannabinoids that are really, really potent, which shouldn't be used, but when you're talking about the natural plant, it cannot kill you. And frankly, it's not even psychoactive in its natural raw form. So, a kid coming up, say you've got your plant in your house or out in your garden, and some little kid comes up, all he's going to get is a little nutrition out of it. Not going to get high because the THC is not active in a fresh plant.
That's amazing.
So we've scared everybody about this plant that I look at as, I think it's one of the most wonderful, beneficial plants on the planet. I mean, and you think about it, because everything from the root to the stem to the leaves to the flowers, everything's good. The seeds, highly, highly nutritious. I'm giving you a long story, but it was this awakening of, oh my God, there's other uses. And then reading the history and finding out, why don't we know this? It's just been hidden from us, and just marijuana. It's the gateway drug to every, next thing you know, they'll be shooting up heroin.
Right. And that's what they say, slippery slope, slippery slope. And that's what I've been told. And that's the medicine I've taken. So, meaning that's what those beliefs, those wrong beliefs. So for people that need a little bit more, what's the difference between cannabis and marijuana? What is the difference?
That's good too, because right now we're also trying to find the difference between hemp and marijuana. And
okay. Yeah.
Cannabis is the plant.
Okay.
And if it's low in THC and grown primarily for the stalk, we call it hemp. Okay. Legally in the United States, it's 0.3% THC will be hemp. 0.3% of THC or lower is hemp. Okay. You get over that, now nobody's going to go smoke hemp. I mean, nowadays, 10%, okay, that's 5 to 10%. Yes, they make even stronger strains, which it's the prohibition that's making the stronger and stronger strains in THC, which is hurting all of us, because that natural plant has hundreds of cannabinoids and terpenes and all these other constituents in it. And to try to drive those out and get more and more THC to get the stronger high is not helping with the medicinal value of it, of the whole synergy of all the different constituents in cannabis. What do you say?
Yeah, I know. No, this is so good. This is so good. And because I think inquiring minds want to know.
Yeah, so marijuana, I think people should just think of marijuana as a slang term. And unfortunately, it has a nice connotation to it in many ways, Mary Jane, whatever, and it's supposed to be something good, but we've made it into something bad. Right. And we keep saying cannabis to say that's the name of the plant. Okay. And it's been around forever. And if you look up cannabis, then you've got this world of history, long history. When you look up marijuana, it's really from the late 1930s and on when they started the reefer madness.
I had no idea. So in Ohio, they have legalized this in Ohio for medicinal usage. So it's around. But another term that I would need help with is, tell me about the Endocannabinoid System. What's that?
Okay, I think everybody's heard of endorphins.
Yes.
We make morphine-like chemicals. So, you get hurt or something and your body puts this out and helps you feel better. We also make cannabinoids. So there's this endogenous or endocannabinoid system. In 1988, a lab in Lynn at St. Louis University in Missouri discovered that we have receptors in our brain for cannabinoids. And, the word got out and people were going, hey, we're wired for pot. And the researchers was going, nah, there's something more. There's got to be something in the body. So 4 years later in Israel, Raphael Meshulam's lab discovered anandamide, which is a cannabinoid made in the human body. They chose the name anandamide. It means bliss in Sanskrit. So now we've got an endogenous ligand, this cannabinoid that fits in with the receptors, CB1 receptors. So these are called CB1 receptors, primarily in the brain. Later, they found receptors primarily in the immune system and throughout the body, but they call them CB2 receptors. A If you fast forward today, what we know now is there is this molecular signaling system throughout our body. And its whole purpose is to keep us in balance, to just kind of help regulate things, to, your seizure, for seizure disorders, calm the electrical activity down in the brain to stop those seizures, help people sleep. Remember, so much chronic pain is from nerve damage, and to just quiet that down and help things. So its whole purpose is to keep us in balance. So in many ways, it's like a master system in our human body. I mean, again, it is so important to help keep that endocannabinoid system in balance. And to an extent, cannabis comes in handy it's got cannabinoids that will interact with those receptors if our own endocannabinoid system is not working that well. Raphael Mechoulam, I think in one of his talks said something about it. It looks like the endocannabinoid system is involved in almost every physiological action going on in our body. The other thing that they discovered with your nerves, and again, my anatomy physiology, I'm not the best at that. It's been a lot of years ago that I went to college. But with our nerves, coming, and there's this synaptic cleft. So the electrical impulses go from one nerve to the other, and there's this little cleft in there, and you see how the electrical activity happens. Well, we always thought it was going one way. And what they discovered was what the cannabinoids were on the postsynaptic cleft, and they would go what's called retrograde. They would back up. They would go back. So they could like turn off the faucet or turn some activity off. And to an extent, that's how they could regulate. They could let something, keep moving or slow some kind of activity down. And it's very, very complex, to say the least. But it's fascinating. And not that long ago, Ethan Russo, a neurologist who's well-versed in cannabis, in the whole study of cannabis, he introduced the concept of an endocannabinoid deficiency. And the article was specifically for migraine headaches, fibromyalgia, and irritable bowel syndrome. I think that was around 2004. And you fast forward to 2016 or something like that, and he just expanded on that. It looks like multiple sclerosis, ALS or Lou Gehrig's disease might be an endocannabinoid deficiency, autism, and again, not only some cancers, post-traumatic stress. Post-traumatic stress symptoms I can understand clearly because someone has been so stressed. Their endocannabinoid system, which is supposed to keep you in balance, protect you from stressors, is just bombarded with horrific, some kind of trauma, and they just feel totally out of whack. And I tell you, I've talked to so many veterans who've used cannabis for this, and their usual comment is, "I feel normal again." It's literally calm things down for them. They can sleep. The nightmares aren't as bad, whatever, but it's just calm things down. Because physiologically, they have changed. Something that irritates you or me can set them off, into, just high state of anxiety or anger or, whatever, like fight back, the fight or flight, and they're ready to fight at nothing. But it's just their whole body's reacting. The chemicals in their body react like that.
Wow.
So, here's something that can just help them get back to in balance.
Right. Is cannabis addictive?
Good question. In studies when people try to rate it, and the common thing is they'll say, well, 9% or so of people who use it will become addicted. And frankly, I kind of think that's high. Although today, when we talk about different ways of using it, one of the ways young people are using it is what's called dabbing. It's taking concentrates of cannabis. It's not the leaf. They're making concentrates of the cannabis, 90% THC or something really, really high, and putting them on like a titanium nail or something. You put a blowtorch to it, heat it really, really hot, drop some oil on and inhale. So it's an extreme heavy hit. And I think a lot of us, we need the research on this, but I worry about doing that day in, day out. What is that doing to your own endocannabinoid system? Right. Is it shutting it down? Are the receptors kind of, what the heck? And we don't need to make that many cannabinoids because we're getting this flood of them. So Yes, I think it can be addictive, but on the scale, when you compare it to all the other drugs out there, some prescribed and others, whether it be cigarettes, caffeine. In fact, two leading researchers, Henningfield, let's see, one was a NIDA researcher and one was a researcher at University of California, San Francisco. Henningfield, I'm going blank on the other name, but they were asked to rate like nicotine, caffeine, alcohol, heroin. They had an opiate in there, and marijuana.
Mm-hmm.
Marijuana, they literally put down as least addictive of all of them. Tolerance down at the level, the high, the physical dependence and addiction, which is more mental and physical. There's a real strong component when you're talking about addiction, because people can be dependent on opiates, and you can get them through the withdrawal and they'll be fine. But if they're addicted, there's this, I got to have it, and they'll go back to it. But anyway, it was rated the lowest or tied with caffeine, except for intoxication. It's more intoxicating, than nicotine or caffeine. So when you think about that rationally, I mean, if you looked at that and you said, gee, I'd like to do something to relax or socially, sure beats alcohol in terms of the dangers. So, it's not, and for if someone did have an addiction problem to it, the therapy is generally like cognitive therapy. You certainly aren't going to go inpatient. Don't use medications, although they've talked about using meds. In nowadays, Marinol is legal. Marinol is THC in sesame seed oil. So, and it was made available on the market in 1985, in the mid 80s. It was started out as a Schedule 2 medication, and there was no diversion. People didn't want it. It's not fun. I don't think patients who used it didn't, it was just too strong for them.
Right.
But it did help with nausea and vomiting, but there was no diversion. So they lowered it to Schedule 3. And normally they might make something more restricted, but this is like one of the first meds that they actually made less restrictive because there weren't any problems. But people thought about, well, we could use Marinol to help with the marijuana addiction. And I'm like, oh, because it's a pill and you're thinking that marijuana people are smoking this, but it's like the pill is the pure THC. That just seems silly to do. Well, more recently, there's, people consider CBD. Maybe you can use CBD, a non-intoxicating cannabinoid that will help somebody feel a little stable and get away from marijuana. That's a thought. But again, I would stress to people, it really isn't that addictive. It can be, they've done studies. People can get addicted to a placebo. There's a mental aspect to it that I
Absolutely.
think I need it.
I have seen that. What ailments, health problems can cannabis be good for, do you think?
Wow.
We're dealing mostly with people with, dementia.
Yeah. And not that all people with dementia are elderly, but
right.
I was going to say, well, especially for the elderly, but there's a lot of uses for it. It's, my goodness, it's helped with seizure disorder. Let's start with migraine headaches, glaucoma, appetite. We all know about the munchies, or appetite is a big thing. People with Crohn's disease, irritable bowel, they found that gets calmed down. They don't have to be running to the bathroom as much. Various cancers, it might help with the cancer pain. It'll help with the nausea and vomiting. It'll help with their sleep. And for some people, it has actually worked on the tumors. Now we can't say it cures cancer or anything like that. There's so much more research we need on that.
Oh yeah, for sure.
And it's clearly getting the right cannabis for those issues. Multiple sclerosis, helping with spasticity, chronic pain, sleep. I'll read articles. I'm a member of the American Nurses Association. And so, I'm getting the daily little top articles or something there. And I don't know how every day I'm like, they could try cannabis. They could try cannabis, and you just all these new meds that are out for certain things. And then you get the list of side effects and I'm like, try cannabis first.
The list of side effects is always so crazy.
Yeah, and the list of side effects here, if you take too much, and eating is probably the scariest Wait, when you smoke it, you kind of know what happens pretty quickly.
Mm-hmm.
When you eat it, it takes a while. It could take a half hour. It could take an hour for some people until.
Sure, like other medicines to max out. Yeah.
And if they take a lot, something heavy duty, and that's a typical one. Oh, a brownie. Oh, okay, I'll have one of those. Ooh, tastes like another one. Gummies. I should say that. Gummies. Oh, let me have another one. Let me have another one. I don't feel anything. Let me have another one. And the next thing you know, something hits them like a wave. And for whatever reason, one of the biggest things that I've heard people complain of, they think they're going to die.
Oh.
ERs look at people, I think I'm going to die.
Okay.
You know, generally, it's put them in a calm room. You're fine. Keep breathing. Relax. It'll pass. But it might be hours until it passes.
Right.
Just too
So we need a
high.
lot more education, but it seems like we are afraid to teach on it because maybe they think that is encouraging more people to use.
Yeah, I think that's it. I mean, I'm going to be teaching at a assisted living, well, at a retirement community. And so I'll be speaking to the independent living folks there. And I want them to know about it because in Virginia, it's legal for medical use and it's legal for adult use.
Mm-hmm.
So they can be using it. And my fear is they're going to go down to one of these local places. And that is the biggest problem. And states where, let me just go off on that. So as you said, Ohio's got its laws, Virginia's got its laws. Every state has a different set of laws.
Right.
State, it's still prohibited. Some states only CBD. I'm going to be speaking in Kentucky. They just passed, it's going to be legal in Kentucky, and you can't smoke it. They had to fight to make sure people could have flower to sell it, because if people wanted to make edibles, they needed the flower, the cannabis flower.
Gotcha.
And granted, if you have the flower, if somebody wants to smoke, they're going to smoke it. But it's illegal to smoke it. And they've got their specific list of what you can use it for. And so to write a recommendation, you have to, okay, it fits that list, I can do it. Oh, that's not on the list. I'm sorry, you can't. So every state is different, which makes it so crazy. And then along with that, we don't have standard labs. That's the biggest, to me, that's the biggest thing. The plant is fine. If you grew your own and you know what you had and it was helpful for you, you could keep doing that. But when you're getting it from someplace else, you want to know what it is. Is it only cannabis? Was something else? You know, I mean, they're talking about fentanyl laced.
Oh my word.
Crazy is that?
Crazy.
You know, so
dangerous too.
So the plant's okay, but you need to know what's in it. And they've sent samples to like 10 different labs and gotten different results. And it's like, wait a minute.
What do you say is the best way to use it? What would be your advice?
It depends on what you need it for.
Say we're doing for my dementia folks, say for confusion, or maybe it is lack of sleep.
I think for dementia, for confusion, for sleep, for something that you want something long acting, an oral. I recommend oral because it will last longer. It might take a little while to get in, but it lasts longer.
Okay.
Smoking has its value in terms of inhaling it will affect you right away. Patients can figure out their dose right away. One inhalation might be it, a low dose.
Okay.
But they might, Bob Randall, one of the federal patients, there was a program where the government was giving patients, they had to go through it was a long deal going through the FDA and NIDA and the DEA to get approval of being on a protocol where you get cannabis from the federal government. But one guy who'd get it, he had 10 cigarettes he had to smoke a day to keep his glaucoma in check.
Wow.
Low dose cannabis wasn't the best one for it. That's where the research is. Would there have been a better variety of cannabis for his glaucoma than what they grew in Mississippi? But what they grew in Mississippi was okay. He just had to smoke a lot of it. But yeah, the oral route is once you figure out what dose would work for you, generally people can take it and it lasts a long time. One of the legal patients, LB Masika, used it for her glaucoma, and she always took it out. By the way, they got really old cannabis from the federal government. I mean, sometimes those canisters were dated like 12 to 15 years old. We don't give people herbal medicines that are that old. We have expiration dates on them.
Yes.
But it still worked for them. But she would take hers and it was dry. And so it burned really easily. But she would use it and make butter and make it in cookies and that. Because for her glaucoma, it kept a steadier state for the eye pressures.
Wow. Now, see, that's very interesting. And more people would want to know that.
Yeah. So the smoking, you'd have to keep doing it to keep this level. You have to know how often you'd have to use it, and fairly often. But so for dementia type things, I would think an oral route. And then the trick is, what's going to be the best variety of cannabis, or what would be most helpful for the dementia?
Right. And you've said, I love the part that you said that we can't overdose on it, because you can overdose on other things.
Yeah.
People die of fentanyl, people die of heroin, people die of those things. But you're saying this, maybe you might fall asleep and then
Right.
you're going to be okay. And I think that's so important to know. Some say it causes short-term memory loss. Is it wise for someone with dementia then to use cannabis? What are your thoughts on that? Or is it that most people, maybe late in the disease is when we give it to them? We know that if you have a real dementia, it's not just a UTI, or it's not just, your thyroid issue. We know it's a true dementia and it's progressing. So is it a big deal if...
Yeah. And a couple of things I'll say. Yeah. And it's the THC that they attribute the short-term memory loss with.
THC.
And generally when you're smoking, I mean, you're just like, what the heck was I just talking about?
Right. Right. Okay.
But there was some research in Ohio. Oh, yeah. I'm going to go blank with this name. Anyway, at the University of Ohio, they did some research on, they're studying Alzheimer's. And with the mice, he presented at our conference in Patients Out of Time. We've been putting on clinical accredited conferences. And he spoke at our conference in 2012 down in Tucson. And his lab assistants, his grad students in the lab, had these T-shirts, "A puff is enough." But what they were finding that in terms of trying to equate it in the mice or rats, whatever, those studies,
Sure.
which we do for a lot of different drugs, but they were finding that it helped prevent the plaque buildup for Alzheimer's. And their thought was, a puff is enough. It just would take a little inhalation a day or something to prevent the development of Alzheimer's, to prevent the development of those plaques. Cannabis it's known as a neuroprotectant, and it's an anti-inflammatory. Again, keeping our body in balance. This thing is trying to protect us from outside stressors. So, okay, that was enlightening. I thought, boy, if I had a family history of Alzheimer's, an inhalation a day, obviously not going to be harmful on that, affect your lungs in any way. That might be a smart thing. But doing more research, it now looks like CBG, cannabigerol, actually help memory. And people can get those. They are available online, and this is not, again, intoxicating. I can't say psychoactive because they are acting with the brain chemistry and all that kind of stuff. But THC is your one that gives you the high. And yes, if you've heard about Delta 8 THC, I encourage people not to go there. It's not normally coming out of the plant. You take the hemp plant, and you got to manipulate this stuff, and depending on how they make it, why go there? Why go try to make something synthetic when the natural plant is there for you?
Right, exactly. So what would be your best advice for my audience? People coming alongside and helping people with dementia, different types of dementia, and their caregivers. Where do they go next to learn about how they could find therapeutic use with this?
There are a lot of places. I'd recommend trying healer.com.
Okay.
That's Dustin Sulek. He's a DO up in Maine. He's been with Patients Out of Time for a long time. He came as an early doc. He came to one of our conferences, and then we turned him into one of our better. Well, he's turned into one of our better speakers. Put it that way. But he was seeing a lot of patients in Maine, and he was a little frustrated because, again, they didn't know what they were getting. Not necessarily getting the same thing. So he started making products.
Okay.
So I know you could go online and people can order just CBG droplets, just to take little droplets in.
I'll make sure that's in the show notes.
Yeah, just CBD. He's got THCA. THCA is THC acid, which is natural in the plant. It's when you smoke it or heat it that the acid part gets knocked off, and it's just THC, the activated, and get too high. But again, for people, THC has medical value. It's really good for nausea and vomiting, and it's helpful for pain. It's helpful in many cancers. So when you've got the dementia patients, are there other things going on? So maybe the CBG could be helpful for the memory, but maybe they want something with some CBG in, or a CBG supplement with the cannabis to help with the sleep, to help with the pain, chronic pain. A topical. If so many patients with their arthritis and they're hurting the knees,
I've
the
heard
shoulders.
that.
I tell you, you can almost do it. They've done it in nursing homes. Just give it to someone and let them start rubbing it. And they're like, then they're sitting down there and they're like, wow, this feels better. I mean, they can notice it right away. You don't have to smoke it. That's just a topical.
Right.
Some places make transdermal patches. Mary's Medicinals in Colorado, I think, were the first to develop that. And I remember hearing from a vet who took it. He says, I had the first night's sleep since I got back from Iraq.
Interesting.
It's a patch that goes on, and usually they'll put it, where the blood vessel's right there or on the ankle, close to blood vessel, and 12 hours or so of slowly getting the medicine. So there are, I mean, they've got vaginal delivery. People have used it for menstrual cramps. They've actually used it kind of to help with sexual activity as well. But you name a way to give it. You can give it by suppository if somebody needs it that way and they can't eat.
Right. And I just love that the side effects are not crazy, because, we're given a lot of the default in my area of my line of work is they're giving antipsychotics, and the side effects are terrible. And when they don't know, they just give more. And what I hate is that frequently we're sedating people into submission when they don't understand how to come alongside and care for them in this disease. And that's what intrigues me about what you do and what you're promoting, is because the side effects aren't anything like that.
And I'll tell you, WAM, WAMM, it's WOMAN, Women's Alliance for Medical Marijuana, started by Valerie Corral in California, Santa Cruz. And she's a head injury person, and they found out that cannabis could help with her seizures. So anyway, she started WAM, and it's basically, in the early days before the laws were changing, they'd talk about cannabis buyers clubs where patients could go and get it, and try to work with the police to say, this is just for patients, don't mess with them. But hers was like a hospice buyers club, but not really a buyers club. They had an area up on the hills, the garden, grow in the garden, paths wide enough for wheelchairs to go through. But most of her patients, 90% were hospice patients. And the point that she'd make there is, you're right. We medicate sometimes just to sedate them, just quiet them down. I don't want to hear the moaning, or they're too confused and they're trying to get out of bed. What she finds with cannabis, it helped with their everyday living, and they were conversing with their family members. She said, it was like beautiful, beautiful deaths. I mean, people weren't drugged and gone. The family was able to say goodbye, to deal with them on a day-to-day basis until they did pass.
Wow, so good. Such great information.
Yeah.
Mary Lynn, I am way over time, but I'm loving this. I could go on and on. So much great information, especially for me who knows very little about it. And I just think it can really apply to so many situations, especially for those living with brain change and are struggling, especially our Lewy body folks. I mean, this could be a huge advantage. So tell me, as we wrap up, tell me how folks can get a hold of you, or what is the next step? If they need more information on this, where do they go next?
Good. Well, you can reach me at ML Mathre, so my name with the initials, at iCloud.com. No problem there. And the better email or website for Patients Out of Time is patientsoutofTime.com. But we're planning, so along with Patients Out of Time, we started ACE, the Academy of Cannabis Education, which is continuing our conference series. So actually, well, there's a couple ways. If anybody lives in the Baltimore area, the Society of Cannabis Clinicians is holding a conference October 12th. Look online for Society of Cannabis Clinicians to find out about that. That's I'll be speaking at that one on addiction, but that'll be a conference. We're looking to the Academy of Cannabis Education to put a conference on in June of 2025 in Charlottesville, Virginia. There's so much to talk about. Nurses, it is now considered a specialty. There are The ANA has this cannabis nursing scope and standards of practice is another area. Online, the Cannabis Nurses Network and the American Cannabis Nurses Association has programs. The Society of Cannabis Clinicians has programs. And healer.com has a lot of free information on their website, asking questions. You can ask questions and get answers. So the stuff's out there. And books, my goodness, Dustin Sulek has a book. Deb Malka, an MD, PhD, has a clinical Pearls for Clinical Practice in Cannabis. The resources really are there. You just have to look for them.
Got it. Got it. Got it. Well, I am so excited that you were able to come on today and share all this information. I'm actually going to have to go back and listen to it several times because there are so many notes I want to take. I will get the important things into the show notes so that folks can find you and they can look further into this topic because, yeah, especially for people that are end stage of things and especially those end stage dementia, how can we make someone comfortable but not just sedate them to the point where they're drooling on themselves and sleeping through life? How about if we could do something? I mean, this could be amazing that they could still communicate with us and we could tell them goodbye. So
Yeah.
anyway, thank you so much for being here. What do you think, guys? She was awesome, Mary Lynn. And I hope that you will seek her information. I will put lots of this into the show notes so you have lots of resources to delve in a little deeper. I need to. I was very green on this topic. So thanks for being here. I hope that you'll like, share, and subscribe so we can get this information out to more and more people. Maybe this needs to be shared on your Facebook pages, on your websites, and so that the great information found here can be utilized. Thanks again for being here, and you know how I feel about this. You got this.